Welcome to Parkinson's TV. My name is Ray Dorsey. I'm a neurologist at the University of Rochester and delighted to be hosting this episode on medications for Parkinson's disease. The goal of Parkinson's TV is to enable individuals with Parkinson's disease and their family and friends to learn about Parkinson's disease, whoever they are, wherever they live, whenever they need that information. To talk and learn more about medications for Parkinson's disease, we have an outstanding panel of guests today. On my left is Dr. Jory Fleischer, who's an assistant professor of neurology at New York University here in New York City. And next to her is Mr. John Andrzejak, who is the Dean of Students at Queens College here in New York City and was diagnosed with Parkinson's disease in 2015. And to my right is Dr. Bas Bloem, professor of neurology at Radboud University in the Netherlands and the creator of ParkinsonNet. Jory, I'd like to start with you. Can you tell us a little bit about the medications that can be used for Parkinson's disease?
Sure. Thanks, Ray. So there are a number of different medications and categories, really, of medications that we use to start treating Parkinson's disease. And I think we can think about them in terms of dopamine. So dopamine is the chemical, the neurotransmitter that is missing, that's deteriorating in people with Parkinson's disease. So we can either replace that dopamine to the best of our ability, and that's with a medication called levodopa. We can mimic that dopamine with something called a dopamine agonist. Or we can use different classes of medications to sort of stretch out the dopamine that you have or prevent the recycling of the dopamine that you have or the dopamine that we give you. So those are things like COMT inhibitors or MAOIs.
And when someone's first thinking about taking medications for Parkinson's disease, what should their considerations be?
I think there are a number of considerations. I think one of the misconceptions about Parkinson's is that there's a sort of standard that everyone takes, or that you start with this one and then you take this one, and there really is no cookbook for this because every single person with Parkinson's is different, and so the medications really should be individualized to that person. So maybe maybe tremor is their most bothersome symptom, or maybe it's slowness of movement, or maybe it's stiffness, and we can address those in different ways. And I think we also need to think about, what is that person doing? Are they able to take a medicine multiple times a day, or are they so busy that maybe just being able to do something once a day and go on with the rest of their lives is the most important thing. So not just what are their symptoms, but how does the medication taking fit into their life? Because otherwise I think it's hard to be successful.
John, can you tell us a little bit about the medications that you take?
Yeah, I started with Azilect, and I'm now taking Azilect and Mirapex.
And before you started taking medications, what led you to decide that now is the time to take medication?
Well, my doctor, and the symptoms were a bit annoying. I had a shuffling gait. My right arm didn't swing naturally. It locked at my side, and my toes curling under, which is just maddening. You're just sitting there and all of a sudden your toes start to curl underneath.
So the symptoms that you had were sufficient that you didn't want to live with them without treatment?
Absolutely.
And you had tried exercise, I hope, before you started your medications?
I'm actually a part-time fitness instructor.
Outstanding. And then Azilect or rasagiline, which is an MAOB inhibitor, is often used as a first-line agent for Parkinson's disease. Can you tell us a little bit about your experience with that medication?
At first I thought it was doing nothing. And then one day I was listening to the Michael J. Fox book on audiobook in the car, and he was talking about how he had to put on shoes just to go to the bathroom, and I realized my toes are no longer curling under. But it did nothing for my gait, my shuffling gait, or my arm swing. So then I started with the Mirapex, and within 2 or 3 weeks, they pretty much go away. When things get stressful, I notice that my arm sometimes locks up and I shuffle a little bit. But by and large, people don't even notice.
And Mirapex or pramipexole is one of those synthetic dopamines that has helped your symptoms. Have you had any side effects from the medicine?
Yes, I have a little bit of impulse control and a little bit of hypersexuality. What do patients say? Mirapex, Mirasex?
Jory, can you tell us a little bit about what impulse control disorder is and what the symptoms can be?
Sure. So when we think about dopamine, we often think about it in the context of dopamine helping movement, but dopamine also mediates the reward pathways in your brain. And so it kind of makes sense that if you're messing around a little bit with dopamine, you might mess around with some of those reward pathways. And so especially with the class of medications called dopamine agonists, like pramipexole or ropinirole or rotigotine, sometimes we can see that a person who previously wasn't doing something addictive, like gambling or excessive shopping or binge eating, suddenly starts to do more of those. It tends to be kind of dose dependent, in that the higher the dose, the more likely to see this and the more difficult it can be. But hypersexuality is one of those things, lots of shopping. So if, I tell people, if suddenly you're spending all of your money on QVC or you're buying Snuggies for your dogs, you need to call and tell me because there's a problem. So those are the things that we worry about.
John, anything else you want to add on that topic?
No.
Now, sometimes these can be actually very concerning and very serious and lead to devastation of not only an individual's life, but the lives of people around them. Can you talk a little bit about that, Boss?
About the impact of Parkinson's in
Or
general?
no, impulse control disorders.
No, we're only gradually beginning to realize that these are more common than we used to think. Up to 30% of patients on a dopamine agonist more or less has these problems. It can be devastating in up to maybe 10% of patients. Gambling can lead to massive loss of money. The sexual impulse control disorders can lead to devastating consequences in the family. So the impact is tremendous. And we often fail to ask about it. Patients are maybe ashamed to talk about it. It kicks in gradually. And one of the really risky things is you start the medication and this impulse control disorder may develop sometimes up to years after you've started the medication. So it's critical that as a patient and as a spouse, you remain alert that this might develop. And as a physician, we constantly need to keep asking about it. So even if it doesn't kick in immediately, it can still arise later in the course of the treatment.
And sometimes these can be very disabling. People can, solicit prostitutes. People can lose their retirement savings. People can, gain 50 pounds. And I think it's important for clinicians to ask people about this. And it's not a shortcoming of the individual. It's the medication itself. We're
Exactly.
changing the chemistry in the brain, and it's leading people to engage in behaviors that they themselves actually don't want to engage in.
And I think that's a critical point, because sometimes the spouse blames the patient for their change in behavior, and there's nobody to blame. It's the drugs that cause these changes in behavior. So please be alert about this and try to be open and discuss it with your physician.
And it's treatable.
It is treatable. I mean, I think one of the misconceptions when I start patients on a medication like this, we go over this sort of initially and say, look, if you develop any of these symptoms, I need you to tell me. I need you to call me immediately. We need to talk about it because we can lower the dose of the medication. We can choose alternative medications. And I think sometimes people will say, no, well, I've never gambled, or I've never been like that, so it's not going to be a problem. But again, it's reinforcing that this isn't you. This isn't a problem with you. This is what happens when we change those pathways in the chemistry of the brain.
We've talked about two medications that people often use to start, both of which you're on, rasagiline or Azlect, an MAOB inhibitor, and then pramipexole or Mirapex, a synthetic dopamine or dopamine agonist. Jory, can you tell us a little bit about levodopa?
Sure. So levodopa is sort of the oldest medication that we really have for Parkinson's. Essentially, it was, people were working in a lab and trying to come up with dopamine, and they found a way to create essentially the dopamine that your brain makes. Once we get it to the brain, sort of past this blood-brain barrier, it is the dopamine that your brain usually is making. And it's still sort of the safest and best, most powerful medication that we have for Parkinson's. Does that mean that it's the right medication for everyone all the time? No, but I think there are a lot of misconceptions out there about levodopa, especially since we know how powerful it is.
John, can you tell us a little bit about what you know about levodopa and your thoughts about taking the medication or not taking the medication?
When I first started to think that I might have Parkinson's and I was waiting to see Jory, that was the first thing that I thought of. Oh, I would have to take levodopa. I started looking on the internet and found out that people shake from long-term use of it, and I was sort of resigned to that happening. So I was delighted to find out that I didn't have to start on levodopa.
Some people have this concern about starting on levodopa, in part, I think, because of concerns about dyskinesias or
Yes.
extra movements that are associated with it. Can you tell us a little bit about your concerns about starting it?
That was my concern, and my concern that I brought up with my doctor was, if I start with that, the long-term use causes dyskinesias. Of course, you look at people like Michael J. Fox, and am I going to be shaking like that? Is that going to be me in a few years down the road? You sit in the waiting room with a lot of people who are older than you, and you know, I already have very difficulty writing, so I thought, oh my God, with the dyskinesia, it would be next to impossible.
So levodopa is by far the most effective medication for Parkinson's disease. Boss, can you address some of John's concerns?
Yeah, and I think it's really important to talk about this. So levodopa, as Jory said, is the most powerful drug. Having said that, it's also the drug that's most clearly associated with the dyskinesias, the excessive involuntary movements, when the levodopa, after years of use, starts to cause excessive effects. Now, every patient will sooner or later begin to experience these dyskinesias and response fluctuations. Postponing any type of drug now doesn't make your future any better. They will arise, and patients who postpone their medication in fear of these dyskinesias, and sooner or later they have to start anyway, will do a catch-up sprint and will develop the dyskinesias at the same pace as the people who were using it early on, except you've deprived yourself of quality of life in the first few years. That's not to say you have to take levodopa, but there's no safe drug in that regard. The pramipexole will eventually also begin to cause dyskinesias and response fluctuations. Most patients sooner or later will end up having to use levodopa. And what is really critical is that patients who are listening to this program should not be afraid of levodopa, should not be afraid of any drug. That's not to say you should break the world record in pill taking, but don't be afraid of the drug if there are symptoms or signs that hamper your life. I always say, as a rule of thumb, if Parkinson's interferes with your mobility, your work, your hobbies, or your activities of daily living in a way that hampers you, don't hesitate, take a drug or take extra medication if you're already on medication. And don't be afraid of the side effects, which will eventually happen anyway, and lowering the dose now doesn't make your future any better in that regard.
Can you tell us a little bit about the way you can manage some of these side effects? So dyskinesias happen about 50% of people after 5 years, but by and large, for most people, these are eminently treatable.
Absolutely. So there are a lot of different things that we can do. So we can change sort of the dosing and the frequency of medications to try to stretch things out. We can add other medications to levodopa in the hopes of decreasing the amount of levodopa that a person is on and sort of getting a smoother sort of level of dopamine throughout the day, because that's really what we're trying to do, is to try to replicate, to try to mimic exactly what your brain does without Parkinson's, which is produce a really smooth, steady level of dopamine all day long. The way that the medication is absorbed in the body is to sort of peak and then fall, and peak and then fall. And we wish that there was some magic pill that would give you all levodopa, one smooth level all day long. We think that that would maybe prevent the dyskinesias or prevent the sort of fluctuations and the wearing off. And so trying to tweak the medications to get as close to that steady level as possible is what we can do. So sometimes lowering one, increasing another, supplementing those, or thinking about other more advanced therapies. So this may be a time if someone is really struggling with motor fluctuations or with dyskinesias that we think about deep brain stimulation or DBS as an option for them. Not the right option for every single patient with Parkinson's, but it's a good option for a number of patients.
You also mentioned that you want to try to keep the levodopa levels in the good zone or the on periods. Right. There are some new formulations of levodopa. Do you want to talk about those?
Sure. So people often ask about, is there a controlled release? Is there an extended release? What is that? So carbidopa, levodopa, which is sort of the standard preparation, is an immediate release. And so it lasts in people's system a couple of hours. Tends to last longer when people are early on in the disease, and shorter periods of time as you get later. And so there's a medium form, which is the Cinemet, that's a brand name, Cinemet CR, or controlled release. Unfortunately, it's been around for a while, and we kind of know that the CR really stands for crappy release. It doesn't really last all that long. It's not as predictable as we'd like. And so we can use it sometimes. I think the context in which I see it used is often someone who's going to sleep at night. Maybe they're waking up a couple times in the middle of the night and they really have trouble getting to and from the bathroom. So the controlled release in that sense might last a couple more hours to sort of cover them for that middle of the night awakening, but it's not going to last all the way through the morning, which is often what people are looking for. So one of the newer medications is really an extended release, and it's a capsule that has sort of the immediate, the middle release, and a longer release version all in one pill, and that's called Rytary. That's been around for a little over a year, and so that tends to last longer. It's still not perfect. I think all of us in the community, both doctors and nurses and patients, were hoping that this was going to be something you could take once or twice a day, and it would really last quite a while, and it's certainly not there yet. There are a number of others that are being looked at. There's sort of an accordion pill that's under development that we think will sort of last longer, but we haven't found that perfect thing yet.
You mentioned there were some drugs to treat dyskinesias. Can you tell us a little bit about those?
Sure. So sometimes we'll use a medication called amantadine to treat dyskinesias, and that's a medicine that's been around for a number of years. It was initially developed as a flu medication, and for some people it can be helpful for treating their dyskinesias. There are other medications that sometimes we'll use off-label, so something like memantine or Namenda, which is actually supposed to be for cognition, for helping with thinking. But sometimes we've found that there are benefits to that. It tends to work at the NMDA receptor, which is where we think that the amantadine is also working in relation to these extra movements. And so that can be helpful in some patients as well.
And we're going to talk more about medications for cognition and some of the non-motor symptoms of Parkinson's disease in the second half of this episode. John, a lot of medications, a lot of options. How does someone like you keep track of all this, and does it get intimidating? We have a bunch of pill bottles here in front of you. How do you manage?
Well, I'm currently taking 4 different pills because I have cyclothymia, and I take 2 medications for that as well. So I've got that, pill pop thing that has the days of the week. I feel like my grandmother, I just remember as a child all the pills, but it really does help. You remember, I do take extended release, so I only have to take pills once a day. It can be expensive, even with medical coverage. So if you don't find a patient's assistance fund, my mother has cancer, and she called the drug company directly, and they worked out a deal, and I thought, maybe I should try this. And they did. They worked out like a very, very affordable deal, and they mail it to me.
So I think it's worth bringing this up, especially in the States where many individuals are paying a large amount of money for the medications that they are taking. There are frequently lower cost options, whether for rasagiline and Azlec. There's selegiline, which is a generic medication, the same class of medications, also been shown to be effective for treatment of Parkinson's disease. Some of the newer medications are much more expensive than the others. Anything you want to say on that front?
Yeah, I think, if your doctor is prescribing a medication to you and you get to the pharmacy and the pharmacist says it's going to be some outlandish figure, your options are not don't take the medicine or pay this crazy figure. Call and let your doctor know. Call, most places are very happy to sort of reach out to these patient assistance programs or to try to come up with an alternative, because we want you, that may be our first line treatment if we suggested something, but we don't want you choosing between medication and rent or medication and food or whatever other priority is there. I always tell people that Parkinson's should fit around your life. You should not fit your life around Parkinson's. And so I don't want people putting the medications at the front and center and sacrificing other things around it. There are options.
I think, though, if you are in the States, I changed drug plans, and at first, I think I was paying for one drug like $250 copay every 90 days, and I cut that in half by ordering from Canada. Okay. And then I changed drug plans, and then it was $90 every 30 days, and I got it down to 30 by buying from the drug company directly. So use whatever tricks you can to save money.
Boss, anything else you would like to add on the treatment of motor symptoms with medication?
No, I think Jory said one important thing that I want to reiterate, that's Parkinson's doesn't pause at night. So many patients take their medication for the motor symptoms spread out over the day and then go to sleep, and frequently awake. You need dopamine to sleep well. So a controlled release, a slow release formulation either a dopamine agonist with a long-acting mechanism or a controlled release levodopa formulation taken at bedtime is critical to maintain sleep. If you wake up, you can at least walk. I always tell my patients, if you still wake up at night, try a dispersible form of medication, which is the third type, I guess. There are levodopa tablets that you can dissolve in water and that you can put on your bed by the bedside. So when you wake up, take some extra medication. It allows you to walk better when you need to pee at night, and it allows you to regain your sleep much more easily. I always tell my patients also to take their levodopa with sparkling mineral water, because usually the levodopa, which is an amino acid, dissolves more easily in sparkling in an acid fluid. Could be orange juice. Don't take it with meals, the levodopa, and particularly don't take it with high protein meals. I had patients who stuck their levodopa into Dutch cheese, typical Dutch habit, and they were terrible. And I just told them, get rid of the cheese, try it with sparkling mineral water, and he could walk and was fine again. So those are two things that I'd like to add.
John, in the first part, you mentioned that you have cyclothymia, which can be associated with a depressed mood. Can you tell us a little bit about that?
Yeah, at first I thought I had ADD because, I went from, rapid cycling. In 3 days, I would get about 2 weeks worth of work done, and then for 2 or 3 days, I would hide in my office with the door closed. And the medications really, really helped.
And these symptoms develop before you had the tremor and slowness of movement? When did they develop?
About age 30, so about 20 years ago. At one point, for a short period of time, the bottom dropped out and I was extremely depressed. Jory thought maybe that was an early warning sign, but luckily it went away.
What else were you experiencing around this time?
Just like, racing out of control thoughts. So it would sort of start with being extremely productive and creative, and then my thoughts would be racing so fast that I could accomplish nothing.
Jory, is John alone?
So I think the depressive side of symptoms, certainly John is not alone. I mean, we see depression sometimes predating Parkinson's symptoms, sometimes around the same time, and sometimes cropping up later in the course of Parkinson's in many patients. So up to 40%, if not more, of people with Parkinson's experience depression. And I think there's this misconception, well, yeah, you'd be sad too if someone told you that you had Parkinson's, but you'd be sad too if someone told you that you had diabetes or if you had anything else. This isn't a reaction. This isn't an adjustment disorder to the diagnosis. This is just another symptom of changing brain chemistry. So we think about dopamine changing in the brain, but there's also serotonin and norepinephrine and other neurotransmitters, other chemicals that help regulate mood and anxiety. Those are also changing. So it's very common for people to experience symptoms of depression, and it's really treatable. I think that's one of the most important things, is that this is not just something that you suffer through and you sit in a dark room. We've got a lot of things that we can do, both medication-wise and also non-pharmacologic, to help people get through. I think one of the most important things is realizing that this isn't just you. This isn't, a character flaw. This isn't, you just snap out of it. And I think for patients to know that, but also for families, because I think a lot of times, no one sort of looks at someone with Parkinson's and says, hey, stop the tremor, right? But if someone is depressed or they're sort of apathetic, the family's like, come on, come on, come on. It's not the end of the world. Snap out of it, right? And it's a chemical change just as much as the tremor or the slowness or the stiffness. And so we would never say that about the physical symptoms.
I think two things help: exercise. I've read studies on exercise that show depressed people stay with an exercise plan like 10 times greater rates than non-depressed people. So exercising really helps me. And while depression is real, when I have depression or like severe anxiety, I tell myself this is a symptom of the disease, things are not really that bad, and believe it or not, it actually does help.
John has a lot of insight. Vas, did you want to add something?
No, I think two things about the depression. That it's frequently missed because patients have what we call a so-called mask face, reduced blinking of the eye, reduced facial expression. So people, we say behind the mask you need to really literally look behind the mask to detect the depression. So that goes wrong. The other thing that goes wrong is that sometimes people who are not depressed, people think they are depressed because they have a lost facial expression. So it's critical that as a patient, as a spouse, you bring this issue up with your physician, and that we as physicians need to proactively ask about mood in all of our patients.
John, you're still working. You're the Dean of Students at Queens College here in New York City, a huge college. How many students are at Queens College?
About 19,000.
About 19,000 students. And you still enjoy your work? Can you tell us a little bit about that?
I love my job. I supervise the people who run the student union. I supervise the people who run the clubs and organizations, the student life and the student government. I supervise the student conduct area, which I actually really enjoy, and Veterans Affairs, and the number of vets returning to work in our country has significantly increased, and they're just wonderful students.
Has Parkinson's affected your ability to work?
No, not at all. I have some life hacks. I found that I could no longer open the door with one hand, so I have like a shelf outside my door where I put my coffee in my bag, and then I open the door kind of with the key in my hip, and then I grab the stuff. Because bending over is difficult for me, and so putting the stuff on the ground and then opening the door and then bending over became quite a chore. Some people complained about the shelf, and I said, if you get Parkinson's, I'll buy you a shelf.
Jory, many people with Parkinson's do have some cognitive impairment that comes on usually slowly throughout the course of the disease. Can you tell us a little bit about that and how that can be treated?
So I think there are a number of ways that we can treat that. The first is to recognize that this can be an issue, both for patients and for caregivers to understand that, if someone is having trouble sort of misplacing things, if someone is having trouble with attention, someone who used to be able to juggle multiple things or multitask really well and now might be struggling, that's part of this, and we want to know because we can help with things. So there are simple non-medication things that we can do. Sometimes occupational therapy or speech therapy can do cognitive rehabilitation therapy, which is something we don't talk about very much, but it's basically sort of finding strategies and workarounds to help with some of these cognitive issues. And if those don't work, there are several medications that we can try. So there's a class of medications called cholinesterase inhibitors, and those were really developed for people with Alzheimer's disease. And in that setting with Alzheimer's disease, the hope was maybe this slows down the progression of cognitive impairment. And it's kind of a catch-22, because if you're on a medication to slow down something else and you're not expecting to see an improvement, right, how do you know if it's working? People started using these medications for individuals with Parkinson's and found that, yeah, it actually seems to help. And sometimes we see not just stabilization, but sometimes patients come back and report actual improvement. They feel like their thinking is clearer. They feel like they're better organized. Caregivers and family members will say, no, really, like things are definitely better. So it's not a guarantee. It's not perfect for everyone, but they can be really helpful. Those are things like donepezil or Aricept or rivastigmine. Those can be very helpful. We also have medications called memantine and meds like that, which are a different class of medicine, but those can also be used for cognition.
Abbas, Jory was talking about medications to improve cognition. Sometimes the medications we prescribe make people's cognition worse. Can you talk a little bit about that?
Yeah, for example, benzodiazepines are commonly used by people with Parkinson's disease. It's not rare for people to receive multiple types of benzodiazepines, for example, as a sleep drug, sometimes to relieve anxiety. Sometimes a doctor who is less experienced in Parkinson's disease thinks a benzodiazepine is good to treat rigidity. And we know that these benzodiazepines have a sedative effect, reduce your agility, and they are the #1 contributor to falls in the United States and the #1 contributor to hip fractures. So, and when you have Parkinson's to boot, benzodiazepines are extra risky. So that's one class of medications where we are very careful in prescribing that to people with Parkinson's.
Just on those for our viewers, those would be drugs that are brand names in the United States are Xanax, Ativan, Klonopin, especially in higher doses.
Exactly. Taking multiple ones is definitely not a good idea, and I would always critically review whether there's still a real need to prescribe those in any patient with Parkinson's.
And then can you talk a little bit about anticholinergics? Sometimes they're used to treat tremor, but they can really have some prominent side effects.
Yeah, anticholinergics were one of the oldest classes of drugs. We haven't talked about that yet. Jory already said Parkinson's causes complex chemical changes in the brain. One of them is a relative lack of acetylcholine, and anticholinergics can correct that. Anticholinergics, I'm not sure what the brand names are here in the States, but only work for tremor. And it's sometimes still used as a treatment for tremor. I still think the best anti-tremor drug is levodopa and not an anticholinergic. Anticholinergics have a lot of side effects like dry eyes, dry mouth, but also enhanced slowness of thinking. Kicks in gradually, and many people who have been on an anticholinergic for a long time, you stop the drug and they say, I feel refreshed.
The cloud has lifted, so in the United States it's trihexyphenidyl or Artane, often used to treat tremor, but can have significant cognitive side effects, especially as people age.
Exactly.
John, there's a whole bunch of symptoms associated with Parkinson's disease that have nothing to do with tremor or slowness of movement, including constipation, overactive bladder, sexual dysfunction. We talked about depression and anxiety. Any of these affecting you? Or
just depression and anxiety, thank God. So I often tell Jory I'm the world's luckiest person with Parkinson's.
So some of these are this autonomic dysfunction, an overactive bladder, or constipation, very commonly found in Parkinson's disease, but very treatable.
Absolutely. So constipation, I think the more we ask about it, the more we realize that it's present in so many of our patients. And there are a tremendous number of things that we can do. First of all, making sure someone is really adequately hydrated. That makes a big difference. I think a lot of people are kind of chronically dehydrated, and I'm the first to admit it. People don't drink that much water, right? We're totally good. And if you're not a big water drinker, make it interesting. Spa water is really big right now, right? So like throw some lemon, throw some cucumber, carry a bottle with you. Any kind of reminder, I think, helps. Exercise helps, keep the bowels moving. But if those aren't working, there are a lot of different things that we can use for constipation. So easy over-the-counter things like Miralax, or generic equivalents of that can be very helpful and don't tend to, your body doesn't tend to get used to them as much as something like Senna or Docusate or things like that. But all of these are available and can help, because the more backed up a person gets, it's harder for the medications to actually work as effectively as they should. And constipation can also lead people to wind up in the hospital. So it seems like sort of a bother if you don't have it, but to someone living with chronic constipation, they know how difficult that can be, and it can also be potentially really hazardous to your health. So it's easily treatable. Also just dietary stuff, adding more fiber, taking away some of the processed food, that can really help. And there are prescription medications that we have for constipation if those first-line things have failed. I think for urination, sometimes people, because Parkinson's tends to affect people as they're getting older, there's often an assumption, it's normal that I have to get up and pee 3 times, I'm getting older. But that's not necessarily the case. Some of it may be related to Parkinson's, and we can treat that. I think it's also important to know, because sleep is so critical to Parkinson's. So if you're chronically sleep deprived because you're waking up to pee all night long, if we can fix that part and get you to sleep better, your Parkinson's will be better in the morning. And so there's, talking with your neurologist. Sometimes the neurologist may refer you to a urologist who specializes in the urinary tract, and can recommend certain medications, because some are preferable and have fewer cognitive side effects and other side effects than some other options out there.
Bas, anything you want to add on autonomic dysfunction, maybe about many people get lightheaded when they stand up?
Yeah. Autonomic dysfunction is the part of the autonomic nervous system is the part of the nervous system that's outside the will, controls things such as blood pressure and your heart rate. A common symptom in people with Parkinson's disease is lightheadedness when they rapidly rise, or with prolonged standing. For example, when you see a crowd marching in and you're standing up for a long time, you get lightheaded. You might even lose your consciousness and drop to the floor, so it's a risk factor for falls and maybe even fractures or other injuries. There are definitely tricks to prevent that. Most of the time in Parkinson's patients, it's a combination of the disease but also the medication. So to critically review the medication is one trick. There are tricks like contracting your muscles while you're standing to pump the blood back up to your brain. Compression stockings have often been prescribed, are not helpful to treat it. It's cumbersome and it's a mess to put them on, and they're not helpful. So a physiotherapist can be helpful, reviewing the medications can be helpful. Adequate fluid intake, not only for the intestine, but also for the blood pressure, is critical. And sometimes, if all fails, induced hypertension, which people generally want to avoid at all cost, is not too bad for people with Parkinson's disease to fight the drop in blood pressure when you rise.
And so many people, when they stand up, they feel lightheaded or dizzy or unsteady, and sometimes they're on medications to lower their blood pressure because they may have had preceding hypertension. And sometimes there are some easy non-pharmacological things that can be done, such as increasing fluid intake, and then sometimes there's some medications that can be all used to treat that. But sometimes the simplest one is just reducing the amount of antihypertensive medications that they're taking. There's a new medication, we'll do this quickly, for psychosis associated with Parkinson's disease in the United States.
Sure. So hallucinations are a symptom that can creep in as Parkinson's progresses, and so people can experience hallucinations or delusions or paranoia, and so there is a new medication called pimavanserin that we can use as one option to try to help treat that. We have some older options, and so talking with your doctor about how much is this bothering you, determining whether they're really frightening hallucinations, are they getting in the way of quality of life, but it's a new option that we have in our toolbox to help treat patients.
Thank you very much. There are a lot of new medications. We can't get to them all, but we'd like to take some questions from our viewers. The first one is, I found out I have Parkinson's disease. When do I need to start taking medications?
Jury said, don't trade tomorrow for today. So if you can take medications and some of your symptoms would go away, I would say immediately. I didn't even think about it. I got the script and went right to the pharmacy.
Don't trade tomorrow for today.
I think it's a beautiful expression. It's the key thing people should remember from today. If there's anything that hampers your daily life, don't hesitate, but start the medication. There's no way that the medication today makes your future worse. We think the opposite. Taking the medication today gives you better quality of life. It allows you to engage in exercise better. We'll have a separate episode on exercise, but exercise itself can work like a drug for people with Parkinson's. And there's even now exciting work. There's a trial in the Netherlands where we're trying to investigate whether early start of levodopa might perhaps even be neuroprotective for the brain to slow down the progression. That's research. That's not been evidenced. It's just to show that this whole fear of medication is outdated.
Jory, can I still drink alcohol when I take medications?
I think you can, and like everything with Parkinson's, I would say in moderation. So I never take away anyone's coffee, I never take away anyone's alcohol, but you should recognize that because people with Parkinson's can have the tendency that when they first stand up, their blood pressure may drop a bit because of this autonomic dysfunction that we talked about, and alcohol can also drop your blood pressure a bit and make you a little bit more susceptible to unsteadiness on your feet, which can happen from the Parkinson's. Be very careful. I wouldn't take alcohol with your meds when you're first starting medications. I would just sort of monitor, make sure that you're well hydrated. I wouldn't go on any binges. So, maybe cut the consumption in half a little bit as you're getting used to medications just to see how it affects you. I think that's the safe way to go.
John, another viewer asked, when's the right time to increase my medications?
I increased my medications when I felt they weren't having the impact that I wanted to. My gait was still shuffling, my arm swing wasn't perfect, so I went to Jory and I said, where is the line between side effect and making the symptoms go away? And I think that that's a good judgment. If you can live with a little bit of imperfection to cut back on the side effects, that's a decision that you have to make. But I increased the medication and the symptoms really, really went down. So I think it gets back to not trading tomorrow for today. I mean, if you can increase your medications a little bit and your arm swings naturally and you don't shuffle when you walk and you're less self-conscious about people looking at you, that really increases your quality of life.
Yeah, and maybe the key thing to say here is it's not the doctor who decides about increasing the medication, it's you as a patient and your family. We know that when we see the patients in our clinic, it's a biased view. Patients always paradoxically do much better in clinic. There are even patients who take an extra pill to look well when they come to see their physician, but you know how you function at home. So the key person to decide about the increase in the medication is the patient and the family, not the doctor.
I think the opposite side of that is you should have a lot of faith in your doctor. Because if you have a lot of faith in your doctor, you're more likely to take their advice. So that was easy with Jory. So
The mission statement in my university medical center, the Radboud, is the patient as a partner. The real slogan should be the doctor as a partner. And if you work as a team, that's the ideal situation.
I think, we know that sometimes, patients will tell us, oh yes, I'm taking all my medications. Oh yes, I'm following all the instructions. And if you're not, that's fine. I would so much rather someone be honest because, right, if John comes to me and he looks under-medicated or he's complaining of some symptom, and I take a look at him and go, okay, well, he's on this much medication or he's on these two, and you just don't look great, so either I need to increase the dose of what you're already taking, what I think you're taking, or I need to add a third medication, or I need to do something else. But if that is based on, my belief that he's taking all the medicines that I think you're taking, but you're actually taking less than that, it only harms the patient. So please be honest. We know that taking medication 3 or 4 times a day is not normal human condition. So if you're struggling to take your medications, tell your doctor that instead of being at risk of having all kinds of complications when we adjust.
John will give you the last word.
I think ask your family how you're doing. It's hard, but ask them to be honest and ask them how you're doing. And I think, with my cyclothymia, I adjusted my medication on my own, and then I went to see my psychiatrist, and I kind of said, I'm cutting this pill in half. And he said, well, you're an intelligent person. Is it working better? And I said, yes. And he said, great, keep cutting the pills in half.
Thank you very much, John. That brings us to the end of this episode on medications for Parkinson's disease. We've been joined by John Andrzejak, who is the Dean of Students at Queens College here in New York City, by Dr. Jory Fleischer, an assistant professor of neurology at New York University, and by Dr. Bas Bloem, a professor of neurology at Radboud University in the Netherlands. The main takeaway is that Parkinson's disease is a treatable condition. Don't suffer in silence. Don't trade off tomorrow for today. With appropriate treatment, your Parkinson's disease can be better and can remain better for many years to come. Thank you very much.